Good morning everyone. I'm here to present about assessing macular thickness in the posterior capsular opacity patients undergoing AIOC capsulotomy, a prospective study. Despite notable advancement in the cataract surgery techniques, the development of the IOLs, the challenge of posterior capsular opacification persists as a prevalent complication. NDF capsulotomy is the standard treatment for PCO, but it has many complications related to the intraocular pressure and also macular thickness. The aim of this study is to investigate how the capsulotomy size influences the changes in the macular thickness. In this study, 30 posterior capsulotomy opacification patients are studied, and inclusion criteria are who are having the PCO, and exclusion criteria who are having corneal opacities, glaucoma, retinopathy, maculopathy, optic neuropathy, diabetes mellitus, and high myopes. This is a prospective observational study, and we have taken baseline best corrected visual acuity and IOP measurements, and the pre-operative pre-laser macular thickness evaluation is done, and the dilatation is done using cyclopentolate and tropicamide, and IOP measurement and the macular thickness assessment is done pre-laser. And capsulotomy size determination is done one week post capsulotomy using the slit lamp and reticule, and post treatment it is done using prednisolone acetate 1% 4 times daily in tapering doses, and statistical analysis is done using SPSS software. And this is the study of this is the table consisting of both capsulotomy size and pre-op and post YAG macular thickness in 30 patients. Coming to the results, we have seen that there is the blue line is depicting the pre-macular thickness pre-laser, and we have seen significant rise in the macular thickness 1 week post laser, and it decreased subsequently at 4 weeks, but it does not reach the baseline. And this is the graph showing the same. And we have seen most of the patients who are between the 2 to 3 mm macular 3 mm size of the capsulotomy, there is a increase in the macular thickness. The R value of our study is 0.65, the P value is 0.0002, and these are the post-op and the pre-op macular thickness. The conclusion, there is a strong positive correlation suggesting the larger capsulotomy sizes are associated with the increased macular thickness. So capsulotomy size is crucial in YAG capsulotomy for posterior capsular opacification, and the increase in the macular thickness. There is strong correlation in the increased macular thickness 1 week after the laser. These findings support an evidence-based approach for better YAG capsulotomy outcomes. These are my references. Thank you. Because whenever we are giving a large capsulotomy, we are giving more shots of the laser, so indirectly it is actually affecting the blood ocular barrier and also vitreous interface. We are disturbing it, so it will lead to the inflammatory mediators to actin and causes the macular thickness increase. Thank you.
Good morning, everyone. My topic is prevalence of low vision among adults and its epidemiological factors, a cross-sectional study at a tertiary healthcare center in Maharashtra. Low vision is defined as a significant visual impairment that cannot be fully corrected with glasses, contact lenses, medication or surgery. Low vision limits daily life and activities. Globally, 253 million people have visual impairment, with 36 million blind and 217 million people severely impaired. Understanding low vision is crucial for public health planning. Epidemiological research on visual impairment has mainly focused on southern India. Northern states lack comprehensive data on the prevalence and associated factors. Knowledge gap impacts eye care planning, particularly in rural areas. By examining the prevalence, severity and determinants of low vision, this study seeks to contribute valuable insights on low vision management and outcomes. Objective is to determine the prevalence of low vision among adults and conditions or diseases causing low vision. Study setting: the cross-sectional study was conducted at the ophthalmology OPD of SMBT Igatpuri. The study included 200 patients aged 18 years and above. Participants had best corrected visual acuity less than 618 but equal to or greater than 360 in the better eye. Additionally, patients with significant visual field loss corresponding to less than 20 degrees were included. Patients meeting the specific age and visual impairment criteria were enrolled. Patients not meeting the age criteria or having visual acuity outside the specified range were excluded from the study. Study of age distribution in patients with low vision is as follows. This table illustrates the prevalence of low vision across various age groups ranging from 10% in the 18 to 30 age group to 33.5 in the above 60 age group. Based on sample of 200 patients, it highlights a trend of decreasing prevalence of low vision with advancing age, reflecting the age-related nature of visual impairment. Following table describes the gender distribution study in patients with low vision. This table depicts the distribution of low vision prevalence among male and female patients, with 67.5% of males and 32.5% of females diagnosed with low vision in a total sample of 200 patients. It highlights a higher prevalence of low vision among males compared to females in the studied population. This table represents the distribution of low vision severity among patients, with 49.5% of cases classified as moderate. Um, the Thank you, ma'am.
Good morning, everyone. हाँ यही वाला. Good morning, everyone. Today I am going to present my e-poster on smartphone photography in ophthalmology. In today's time, we all need to showcase our work, be it the post-op pictures, be it the pre-op, or any rare cases we see in the OPD. So, smartphone can be helpful in assessment of disease progression, regression, or also in patient education. Here we describe a simple way to acquire high quality anterior segment images using a smartphone with just a small portable macro lens attachment. This would help in capturing anterior segment structures with ease and reasonable clarity, thereby aiding in the better assessment of the pathology. We also describe in brief smartphone fundus photography, that is cheap, cost effective and portable method of retinal imaging. First of all, we need to follow some tips such as clean the external camera, as there can be fingerprints of food particles sometimes, learn to focus and set the light exposure as needed. In this video you can see whenever we tap on the anterior the anterior image, or wherever we tap on the screen, it gets focused, and if we hold that, the focus is locked. Then we can set the light exposure to and increase that or decrease that according to the clarity of the image. In the right side you can see that this sclera is more clearly visible when the exposure is decreased. We should concentrate on the image composition and take into frame only the area of pathology. We can communicate with the patient that can improve the compliance and seek assistance if required. This is the small clip-on lens that can be attached to the camera, and it is very easily available on online platforms, and it is also cheap, like it comes of 300 to 400 rupees, and we can focus the images very well with this camera. These are some photographs that we obtained with the help of this attachment. You can see the broken zonules and the stretched out zonules in this image of the traumatic Zorzet cataract. These are some congenital cataracts. You can see the loose sutures of the post-keratoplasty patient. This can be helpful in the ophthalmology, like these patients should be referred for the removal of the sutures. These are some patients with ulcer. The illumination source, we can use the built-in flashlight or the external pen torch or indirect ophthalmoscope for illuminating the pathology. Smartphone fundus photography, the same can be applied on the to take the images of fundus by using the 20D lens and focusing properly. Initially you may face difficulties like glare or the reflections of the light, but uh, while practicing for a bit you can obtain good images just with the help of your phone. So smartphone photography has proved to be accurate and sensitive in comparison with slit lamp photography in various studies. In the vision technicians and ORP workers can be trained to obtain good quality images and improve the decision making. And a simple additional macro lens can be used to harvest the full potential of HDR smartphone cameras. Thank you. Ma'am, the main challenges were focusing on the pathology, like because while using the lens or while taking the photographs, the patient moves the eyes a lot. So the best is to communicate well with the patient that you are going to take 5 minutes or 10 minutes and take some photographs of the patient for his benefit. Yeah, the fundus part you are asking. Yeah, while you do for 10 to 15 patients, you get very used to it. Yeah. Yeah. Actually, I think that whenever you take the photograph, you should write everything like the patient details, or if you are using the EMR, you can like the EMR number in that photograph itself, or there are notes that you can add in the photograph that can help you in later in publishing that part. No, I don't think. Yeah, yeah, I have tried. There is no, yeah, there is no problem. It's just like a slit lamp photograph only. Yeah, thank you.
Good morning, everyone. So I'm here to present a case report on Weil-Marchesani syndrome, a dancer in the posterior chamber. Weil-Marchesani syndrome is an inherited connective tissue disorder characterized by abnormalities of the lens of the eye, secondary glaucoma, short stature, brachydactyly, joint stiffness, and cardiovascular defects. There is impairment in the production of fibrillin, leading to zonular weakness. The highly mobile lens leads to refractive shift, leading to high myopia. The complications could be pupillary block and secondary angle closure glaucoma, etc. A 34-year-old female came to the OPD with complaints of gradual diminution of vision in both eyes. On examination, patient was short-statured with brachydactyly with short and stubby fingers. Slit lamp examination revealed phacodonosis, microspirophakia, and anteriorly dislocated lens. B scan was normal. UBM showed zonules sparsely present. This is examination of the right eye and left eye. On both eye, the fundus was normal. Lens showed phacodonosis, microspirophakia, and anterior dislocation of the lens. IOP was within normal, and the vision in right eye was 2/60. Vision in left eye was 4/60, improving to 636. This is a picture of the patient with the attender, and the patient's finger to demonstrate brachydactyly. Slit lamp examination shows the equator of the lens. Wanted to get a closer look at the image, and this is the right eye showing the dislocation of the lens and microspirophakia, and this is the left eye picture. The patient was diagnosed with Weil-Marchesani syndrome with both eye anteriorly dislocated lens. Patient was planned for both eye lensectomy with secondary IOL implantation. Post-operatively, the patient's vision improved to 624 in both eyes. So the common differential diagnosis for the etiology of microspirophakia is Weil-Marchesani syndrome, Marfan's, Peters anomaly, Klinefelter syndrome, Alport's and Loeys syndrome. The treatment is to intervene early: myopia, the pupillary block, angle closure glaucoma, and lens dislocation. These are the possibilities that we have to think of. This case is presented for its rare occurrence of 1 in 1 lakh population. It has a Weil-Marchesani syndrome has a good prognosis when the microspirophakic lens is removed early. So it improves the visual acuity, control of IOP, and prevents pupillary block and glaucoma. Systemic symptoms may be managed with physical therapy for joint tissues, regular cardiac follow-up to screen for anomalies. Thank you. Thank you.
Good morning everyone. I am going to present a retrospective case series which deals with spectrum of presumed ocular tuberculosis. So tuberculosis, as we know, it's highly endemic in India, and diagnosis is confirmed only by direct visualization of the bacilli, and inaccessibility of ocular tissue makes it quite difficult. So we have to rely on indirect evidences like Monto's test and IGRA to start early ATT, which reduces the mortality as well as morbidity of the disease. So we aim to demonstrate the spectrum of presentation of ocular TB with its demographic distribution, course and response to treatment. So all patients coming to OPD from January 22 to December 23 were included, who were with positive Monto's or IGRA test and had prompt response to ATT. So altogether 16 cases underwent complete ophthalmic and hematological investigations, and those with positive Monto's were sent to referred to TB and chest department for early start of ATT. So there were 9 different presentations. Maximum were of Flick-Tendler conjunctivitis, that is 4 patients, 2 each of episcleritis and antiascleritis, 3 cases of anterior uveitis, and 1 each of retinal vasculitis, optic neuritis, serpiginous-like choroiditis, tacryoadenitis, and orbital cellulitis. 31% patient were comorbid, and almost 70% patients had unilateral presentation, although there was no general distribution. Actually no difference in gender distribution. So primary ocular TB was seen in 14 of the patients, and secondary ocular tuberculosis in 2 of the patients. 5 patients had bilateral presentation, and ATT could be started only in 15 of the patients because 1 patient did not give consent. Systemic steroid was started in 5 patients who had bilateral presentation, and adverse drug reaction in the form of optic atrophy was seen in 3 of the patients. These are some of the case photographs showing Flick-Tendler conjunctivitis pre-treatment and post-treatment day 3, chronic anterior uveitis, and last case, bilateral optic neuritis. So the mean age of presentation was 30 years, the youngest being 13 and oldest 60 years. Flick-Tendler conjunctivitis was the commonest presentation. 56% were with extraocular manifestations, and among intraocular lesions, 43% patient showed optic atrophy. So 80% of the patients with bilateral presentation were with posterior segment presentation and with comorbidities, and 40% had abnormal chest X-ray. 60% on systemic steroids developed optic atrophy. So since most of the extraocular cases are naive and self-limiting, although weaker immune system may pose threat in terms of increased morbidity and mortality. So recurrence and relapse may be disturbing and dangerous, so a very high degree of suspicion is needed. And new effective and confirmatory modalities, and with a larger sample study and longer follow-up are needed for effective understanding. Thank you. Yeah, we had started methylprednisolone. Yeah, one patient who had developed hand movement with bilateral optic neuritis, he had secondary tuberculosis, secondary ocular tuberculosis, because pleural effusion and pulmonary tuberculosis was also diagnosed. So he was referred to chest and TB as well as neurology department. They started IV methylprednisolone, 3 days IV and then on oral dose. No, he did not recover. Thank you. Thank you, ma'am. हम यहाँ नहीं
Good morning, everyone. I am presenting e-poster on surgical challenges in complicated cataract with neovascularization and secondary glaucoma. This is a case of 38-year-old male who is a known case of right chronic uveitis with secondary angle closure glaucoma, presented with right eye visual acuity of hand movement and pressure of intraocular pressure of 42 mm of Hg, uncontrolled on maximal medical therapy. On slit lamp examination, we found AC shallow with iris bombay, small pupil with a fibrous membrane with neovascularization over it, synechia and complicated cataract with no view of fundus. So the patient underwent NDAC PI and NDAC synechiolysis. Thereafter, the IOP was controlled on 2 AGMs. This is the anterior segment imaging after synechiolysis, and we could see the slight nasal opening of the fibrous pupillary membrane and a small hyphema. 3 months later, we planned phacoemulsification with IOL implantation under LA. So the challenges were IOP control, shallow AC, though it deepened to 2.63 after YAG PI and synechiolysis. Multiple adherent licomas, thick occlusio pupillae with neovascularization on membrane, which has the risk of hemorrhage. So the steps we took was use of high molecular weight ophthalmic visco surgical devices. We used viscoat. 2-step clear corneal incision was made to reduce the risk of iris prolapse. Pupillary membrane was carefully removed through the small opening created by synechiolysis. Visco cannula was interred and further opened up, cut with micro scissors and carefully peeled off. Iridocorneal adhesions were managed with viscoaspiration and sweeping movement of the cannula. 4 iris hooks were inserted through the 4 side ports to expand the pupil and to improve the visualization of the cataract. Use of trypan blue and Utratas forceps for capsular access reduced the risk of rhexis runoff. These are the intraoperative photographs. After phacoemulsification, single piece acrylic IOL was placed in the bag. These are the 3 months follow-up photographs of the anterior segment and fundus of the patient, showing patent PI IOL in place and posterior capsular plaque with hazy view of the fundus with approximately CDR of 0.5:1 and del FR. At follow-up at 3 months, the visual acuity unaided was finger counting 4 meter and BCVA 636. IOP was controlled that is 10 mm of Hg on 2 AGMs. With resolving CME, patient is on difluprednate and nepafenec. We could see the OCT pictures showing resolving CME. So I conclude by saying that management of uveitic cataract with refractive secondary glaucomas has high risk of complications, and so meticulous treatment plan needs to be implemented even if we have slightest chance of recovery of vision. Thank you. Yes, ma'am. Initially, the patient was on oral. For the management, we are planning for PST or intravitreal steroids if the vision will still not respond. Yes, ma'am. Yes.